I'm Deypalan from President 2 Wiedenbach, and today I'll be performing nasogastric tube feeding. It is the installation of specially prepared nutrients into the stomach through a nasogastric tube. Objectives: to provide alternate means of ingesting nutrients for patients with functional gastrointestinal tract, to intervene in pre-existing or impending nutritional depletion from debilitation, to provide aggressive management for certain disease conditions, to provide means of nutrition if there is an inability to swallow or an existing obstruction in upper alimentary canal, to provide nutrients for patients in comatose or semi-conscious state, to provide increased nutrients requirements above oral consumptions, to provide nutrients for post-operative patients with bowel sound present, to maintain fluid and electrolyte balance. Equipments: disposable feeding bag, 20 to 50 ml syringe, stethoscope, pH indicator tip, prescribed enteral feeding or formula, gloves, equipment to obtain blood glucose by finger stick, kidney basin, water to follow feeding, measuring container, and tissue. Prepare all necessary supplies. Explain the procedure. Discussion and explanation help allay anxiety, encourage patient cooperation, and prepare the patient for what to expect. Perform hand hygiene. Put on gloves. Prepare feeding container to administer formula. Have tube feeding at room temperature. Cold formula may cause gastric cramping and discomfort because the liquid is not warmed by mouth and esophagus. Shake formula container well. Fill container and tubing with formula. Filling the tubing with formula prevents excess air from entering GI tract. Place client in high Fowler's position or elevate head of bed 30 degrees. The elevated head helps prevent aspiration. Determine tube placement. Aspirate gastric contents to check for gastric residual. Return aspirated contents to stomach unless the volume exceeds 150 ml. Presence of gastric secretions indicates that the distal end of the tube is in the stomach. Residual volume indicates if gastric emptying is delayed. Delayed gastric emptying may be reflected by 150 ml or more, remaining in the client's stomach. Measure pH of aspirated GI contents. Fasting gastric pH is usually equal to or less than 4. It is only infrequently greater than 6. In contrast, intestinal aspirates usually have a pH equal to or greater than 7. Observe aspirates appearance. Gastric fluid is usually cloudy and grassy green or tan or off-white in color. In contrast, intestinal fluid is usually deep golden brown and is clearer than gastric contents. Consider the result from pH testing and the aspirate's appearance together. An aspirate with a low pH and the typical gastric fluid color indicates a high probability of gastric placement. In contrast, a golden-colored aspirate with a high pH indicates a high probability of intestinal placement. Initiate feeding. Bolus or intermittent feeding. Pinch proximal end of the feeding tube. It prevents air from entering client's stomach. Remove plunger from syringe and attach barrel of syringe to end of tube. Fill syringe with measured amount of formula. Release tube and hold syringe high enough to allow it to empty gradually by gravity. Refill. Repeat until prescribed amount has been delivered to the client. Gradual emptying of the tube feeding by gravity from syringe or feeding bag reduces risk of abdominal discomfort, vomiting, or diarrhea induced by bolus or too rapid infusion of tube feedings. Advance tube feeding gradually. Tube feeding should be advanced gradually to prevent diarrhea and gastric intolerance to formula. When tube feedings are not being administered, cap or clamp the proximal end of the feeding tube. This prevents air from entering stomach between feedings. Administer water via feeding tube as ordered with diluted formula. Provides client with source of water to help maintain fluid and electrolyte balance. Rinse bag and tubing with warm water whenever feedings are interrupted. Rinsing bag and tubing with warm water clears old tube feedings and reduces bacterial growth. Measure amount of aspirate or residual every 4 hours. This evaluates tolerance of tube feeding. Monitor fingerstick blood glucose every 6 hours until maximum administration rate is reached and maintained for 24 hours. These alert nurse to client tolerance of glucose. Monitor intake and output every 24 hours. Intake and output are indicates of fluid balance or fluid volume excess or deficit. Weigh client daily until maximum administration rate is reached and maintained for 24 hours. Then weigh the client 3 times per week. Weight gain is indicator of improved nutritional status. However, sudden gain of more than 2 pounds in 24 hours usually indicates fluid retention. Observe the return of normal laboratory values. Improving laboratory values such as albumin, transferrin, and p-albumin indicates an improved nutritional status. Evaluation. Patient tolerates feeding well and weight is maintained or increased. Appropriate residual is obtained from aspiration of stomach contents. Patient complies with feeding procedure. Intake and output balance is maintained. Nasogastric tube functions efficiently and remains patent.